Assalamu alaikum. To continue our lectures regarding the general physical examination. So after we finish examining the face of the patients, looking for jaundice, for cyanosis, for anemia, examination for hair distribution, for any finding asymmetry in the face, then you have to examine the neck of the patient. The important structures in the neck to be examined is the lymphadenopathies and the thyroid gland. We discussed the lymphadenopathies previously. Then today we are going to examine the thyroid gland. Examination of the thyroid gland consists of three portions: inspection, palpation. These are the main techniques used: inspection and palpation, and you have to synthesize these data and these techniques. And sometimes you can add percussion of the upper part of the chest when the patient have a big goiter. Goiter means enlargement of the gland, big goiter with the retrosternal extension. So you may need to percuss the upper part of the chest, or you may need to auscultate the goiter, the thyroid gland, when the patient have, for example, Graves' disease or thyrotoxicosis, and you may hear a bruit or murmur. Then you have to inspect the thyroid gland, and both inspection and palpation you may need use sips of water, and you notice the movement of the thyroid gland during deglutition or during swallowing. Inspection of the thyroid gland by anterior approach, the patient should be seated or standing in position and should be comfortable with the neck in a neutral or slightly extended position. To enhance visualization of the thyroid gland, you can extend the neck which stretches overlying tissues, and have the patient swallow a sip of water, as I mentioned. So during inspection, you have to ask the patient to drink sips of water, and during swallowing, during deglutition, you can inspect and can see the movement of the thyroid gland with deglutition. As we know that the weight of the gland is between 10 to 25 grams. This is the method of inspection of the thyroid gland. So you ask the patient to drink sips of water, and during swallowing you have to notice the movement of the gland with deglutition. This is the anatomy of the thyroid gland, composed of the thyroid cartilage. It's very important to notice the thyroid cartilage and the cricoid cartilage. Then this is the gland, between 10 to 25 grams the weight, and this is the trachea, composed from the left and right lobe, and this is the isthmus. This is the both carotid arteries, and this is the left and right gland, and this is the isthmus. This is the thyroid cartilage and the cricothyroid membrane. So after we inspect the thyroid gland, we have to go to palpate the gland, and palpation of the thyroid gland have two approaches, either anterior, or you can stand behind the patient with the posterior approach. حقيقة there is no much difference between anterior and posterior، ولو preferably يفضل posterior approach. So preferably the thyroid gland should be palpated from behind, and it move with deglutition. وراح نشوف movement with the swallowing of the patient, and ask the patient to swallow sips of water, and you can palpate the gland, whether it is enlarged or not, it is soft or firm in consistency, it's move with mobile, not attached to the underlying structures, tender or not, there is retrosternal extension, or you may hear bruit. The patient is examined in the seated or standing position. أيضا palpation you can do it in sitting position or standing position, and you further in sitting position, and you have to stand on behind of the patient. So you stand behind the patient and attempt to locate the thyroid isthmus by palpating between the cricoid cartilage and the suprasternal notch. You have to move your hands laterally to try to feel under the sternocleidomastoid muscles for the fullness of the gland. And during palpation, you have to ask the patient to drink sips of water, to swallow sips of water as you palpate, and feeling for the upward movement of the thyroid gland during swallowing. This is the way to palpate the thyroid gland. If the patient have a thyroid nodule, even you have to locate the thyroid gland perfectly by inspection and by palpation. You have to palpate for the thyroid nodule. You have to mention the size and number of the nodules. You have to mention the consistency of the nodule. واحدة من important cause of nodule هي thyroid cancer. So you have to look for any regional lymphadenopathies and look for the consistency and mobility of the lymph node. This patient got small thyroid nodule, and this is the way to examining for the thyroid gland using 4 fingers, the paths of 4 fingers, just like the examination for lymph node. This patient got big goiters with nodular goiter. This is nodular goiter. This is also nodular goiter. This patient with diffuse goiter and diffuse goiter in patients with Graves' disease, thyrotoxicosis. وراح نشوف الآي signs شلون واضحة. الآي signs of the thyrotoxicosis اللي هي exophthalmos, lid lag, lid retraction, and ophthalmoplegia. Sometimes we can use what we call the Bombertin maneuver or Bombertin signs when there is any suspicion of big goiter وعندنا retrosternal extension. فإذا we think or we suspect retrosternal extension فنطلب منكم تسوون Bombertin test, Bombertin sign, which is used to demonstrate the presence of a latent pressure in the thoracic inlet. This is by asking the patient to elevate both arms until they touches the side of the face. A positive Bombertin sign is marked by the presence of facial congestion and cyanosis. أيضا يصير عندهم respiratory embarrassment, distress after approximately 1 minute. فإذا the sign is positive when there is bilateral arm is elevated and there is facial plethora or facial congestion. A positive Bombertin sign is indicative of superior vena cava syndrome, sometimes commonly the result of a mass in the mediastinum. فمو فقط هي الثايرويد, commonly with thyroid, but any mass in the mediastinum compressing the respiratory passages may cause respiratory embarrassment, although the sign is mostly seen in patients with substernal or retrosternal goiter, where the goiter cocks off the thoracic inlet. The maneuver is potentially useful in any patients with adenopathy, مثلا إذا عندنا big lymph node or tumor or fibrosis. أيضا ممكن يسوينا Bombertin sign just like this. You have to ask the patient to elevate both hands فنشوف شلون هنا الفيس congested and plethora. Now normal facies مالته has big goiter with retrosternal extension, so when we do a Bombertin sign, patient have Bombertin sign positive when there is facial plethora or facial congestion. Now you finish the examination with thyroid gland. You have to go to the examination for the pulsation in the neck. Pulsation in the neck may be arterial pulsation or venous pulsation in the neck. بعدنا بالneck. Venous pulsation is a prominent. شو وقت يشوف prominent venous pulsation when there is congestive cardiac failure, when there is superior vena cava obstruction, or when there is massive pericardial effusion. while arterial pulsation is prominent in aortic incompetence or aortic regurgitation. The difference between arterial and venous pulsation of the neck is very important. هذا دائما سؤال نسألكم. How can you differentiate between this is arterial or no, this is a venous pulsation? Sometimes difficult to differentiate between arterial and venous pulsation. Venous pulsation differentiation, here I have 5 points. Number 1, venous pulsation is visible but not palpable. This is very important. So you can notice and visualize the venous pulsation, but you cannot palpate venous pulsation. While arterial pulsation is usually visible and palpable. Arterial pulsation usually visible and palpable. Venous pulsation only visible, not palpable. Number 2, venous pulsation has two peaks, while arterial pulsation has only one peak. Number 3, venous pulsation obliterated by pressure. فنقدر نسوي pressure at the root of the neck. Pressure. فيصير obliteration. بينما arterial pulsation will not obliterated by pressure at the root of the neck. Number 4, venous pulsation increase by and decrease with the respiratory cycle. So it is increased and decreased with respiration and change of position of the patient. بينما arterial pulsation will not affected by respiratory cycle. So venous pulsation increase and decrease with respiratory cycle and change of position of the patient. بينما arterial pulsation will not. And finally, if you couldn't differentiate so easily, you can press on the liver doing the hepatojugular reflux, which is positive in venous pulsation, but it's negative in arterial pulsation. So you can press the liver by gentle abdominal pressure, فراح نشوف يصير congestion, engorgement of the pulsation. فإذا كانت venous pulsation, it will be prominent. Arterial pulsation will not affected by hepatojugular reflux, أو نقول عليه abdominal pressure. The jugular venous pressure JVP لازم نقيس أيضا jugular venous pressure. فإذا لقينا prominent JVP أو نقول elevated JVP مثل patient عنده congestive cardiac failure, لازم نشوف إنه قد JVP مالته. Normally the JVP is 3 to 4 centimeter above the sternal angle, which is angle of Lewis أو manubrium sterni. The internal jugular vein, طبعا من نقيس ال JVP هو نقيس ال internal jugular vein مو ال external jugular vein. Internal jugular vein, superior vena cava and right atrium are in continuity. So the height of the jugular venous pulsation reflects the right arterial pressure. فكل ما يزداد right arterial pressure يزداد ال jugular venous pressure. In continuity. When the patient is placed at 45 degree فبنريد نسوي ال JVP measurement, لازم ننيم المريض at 45 degree with the head supported and turned to the left. The JVP is visible along the line of the sternocleidomastoid muscle. The JVP falls during inspiration. فمن ياخذ نفس ينزل الجيجولار فينس بريشر، واحنا قلنا هاي الستبس نسويها مع الهيباتوجيجولار وغيرها اذا ما متاكدين من الجيجولار فينس بالسيشن. واحنا دائما نقيس الانترنال جيجولار فين مو الاكسترنال جيجولار فين، وحنقيس الJVP. This is the way to do the JVP. هاي رولر نستخدم هنا رولر، فنقول هنا نقيس هذا الارتفاع نقول 3 to 4 سنتيمتر، مثلا نقول 10 سنتيمتر. كل ما يصعد الJVP راح يصعد عندنا هنا القراءة. So you have to observe for a visible jugular venous pulsation along the sternomastoid muscles، ونخلي هاي مسطرة هنا ومسطرة هنا ونقيس الjugular venous pulsation. It's usually normally it's below 4 centimeter. If it is above نقول elevated jugular venous pulsation, elevated JVP. The height of the JVP is determined by the right arterial pressure and is therefore elevated in right heart failure and reduced. We have low JVP in patients with hypovolemia. If the jugular venous pressure is not easily seen, it may be highlighted by gentle pressure on the abdomen مثل ما قلنا hepatojugular reflux نسوي إذا ما شفنا الJVP obviously. We have Cosmal sign. What is Cosmal sign? Is a paradoxical rise in JVP on inspiration or a failure in fall of JVP with inspiration. فإذا normally احنا من واحد ياخذ نفس jugular venous pulsation تنزل JVP during inspiration. إذا صعدت هذا نسميه Cosmal sign is paradoxical rise in jugular venous pulsation on inspiration. Normal inspiration ينزل JVP. هنا يسأل عندنا JVP. إذا صعد نقول Cosmal sign positive or a failure in fall of the JVP with inspiration, usually indicative of limited right ventricular filling. ليه صار Cosmal sign؟ عندنا معناته right heart dysfunction. Cosmal sign is named after the German doctor who first described it. طبعا عندنا Cosmal sign and you have the Cosmal breathing. فإذا Cosmal sign هو paradoxical rise in jugular venous pulsation during inspiration. This is Cosmal sign. It indicates limited right ventricular filling مثلا بالmassive pericardial effusion. هسه راح نجي causes of Cosmal sign. بس من يجي على بالنا Cosmal sign لازم ايضا نتذكر Cosmal breathing اللي هو deep acidotic breathing, deep sighing breathing with increase in rate or depth of respiration, often associated with severe metabolic acidosis, particularly in diabetic ketoacidosis. بنقول لكم causes of Cosmal breathing, you have to mention the diabetic ketoacidosis, the chronic kidney disease in patients with uremia, and sometimes in aspirin poisoning, and commonly the commonest cause of Cosmal breathing اللي راح نشوفها بالcasualty أو in the hospital or in the clinic were due to hysterical hyperventilation or psychogenic hyperventilation. The jugular venous pulsation has three positive waves, A, C, and V, and we have two negative waves, which is the X and Y descend. So we have ACV, upward descent, upward positive wave, and you have two descend, which is X and Y descend, and نسميها two negative waves, X and Y. The A wave لو نرجع على واحدة واحدة ال A wave شنو, C wave شنو, ال X, ال V and Y. ال A indicate what? Arterial contraction, right arterial contraction. إذا هنا صار عندنا right arterial contraction. This is right arterial contraction. The C wave corresponds to the right ventricular contraction. إذا C wave, this is right ventricular contraction. This is right arterial. هنا right ventricular contraction أقل الصير. The X descent corresponds to the arterial relaxation and rapid arterial filling due to low pressure the right atrium. فإذا ال X correspond to the arterial relaxation. This is arterial relaxation, فراح يدخل الدم in the atrium, يزداد الدم in the atrium, in the right atrium. The V wave correspond to the venous filling when the tricuspid valve is closed and venous pressure increases from venous return. فهنا enters blood in the right atrium, and there is venous filling and congestion. Tricuspid valve is closed. فمن يصير closure of the tricuspid valve تطلع النهاية ال V wave tricuspid valve closure. So the V wave corresponds to the venous filling when the tricuspid valve is closed. The Y descent corresponds to the rapid emptying of the atrium into the ventricle following the opening of the tricuspid valve. The Y descent, this is the opening, this is the closure, and this is the opening of the valve, the tricuspid valve. The jugular venous pulsation is prominent and wavy form in cases of bradycardia, fluid overload, and heart failure. فكلش مهم نفحص ال JVP إذا عندنا evidence of heart failure أو volume overload, fluid overload, and even sometimes in bradycardia where there is low heart rate. but the wave is normal waveform, high bradycardia, fluid overload, or heart failure. Raised jugular venous pulsation with absent pulsation is only prominent. There is no pulsation when there is superior vena cava obstruction, severe vena cava syndrome. Large A wave, increased arterial contraction when there is prominent A wave in jugular venous pulsation, like in tricuspid stenosis, right heart failure, and pulmonary hypertension. Paradoxical J wave اللي هسه قلنا عليه cosmal breathing، يعني بالعكس من ياخذ نفس يصعد عندنا الجوجلر venous pulsation rises with inspiration and drops with expiration, just reverse to the normal respiratory cycle. It occurs, فنقول cosmal sign occurs in pericardial effusion, constructive pericarditis, and pericardial tamponade. So تحفظوها: pericardial effusion, constructive pericarditis, and pericardial tamponade causing cosmal sign. Cosmal sign. These are the causes of elevated JVP, either in waveform or absent, just single wave. And this is very large A wave, and this is the cause of cosmal sign. The raised jugular venous pulsation, the raised of jugular venous pulsation with normal مثل ما قلنا bradycardia, fluid overload, heart failure, raised with absent pulsation with SVC syndrome, large A wave, tricuspid stenosis, right heart failure, and pulmonary hypertension, canon A wave, arterial flutter, premature arterial rhythm, third degree heart block, ventricular ectopics, tachycardia. Absent A wave, JVP بس ماكو A wave, and arterial fibrillation. Large V wave when there's tricuspid regurgitation. Absent X wave in tricuspid regurgitation. Paradoxical هاي حفظوها. Paradoxical cosmal sign هي pericardial effusion, constructive pericarditis, and pericardial tamponade. شوية difficult هذا بالنسبة لكم الجدول، لكنه مهم تاخذون عنه فكرة, and you will take it in details inshallah بالfourth stage in cardiology. Thank you very much.